Thank you so much, gang, for having me. The talks ahead have been just spectacular, and I hope that our audience can appreciate the level of sophistication they're trying to bring to you. I want to talk about the hybrid concept, and I have this titled "The Next New Indication for Vertebral Body Tethering." We'll see how it goes here. I do have some disclosures. These are companies that I have relationships with, both on the research and the development side. You've heard already that the tether can create 3D growth modulation, and I think this is a really important concept. How can we reshape those vertebrae over time using that device? And we have pretty good evidence that with the right amount of growth and the right indication, as you've been hearing, that this can be a very successful operation. But at the same time, you've heard that this cord can break, and the numbers are something like 50% at 3 years by several studies. And when that cord breaks, it's not doing its job anymore. If you finish your growth by the time that cord breaks, may not be a problem if you had lots of modulation. If you didn't, your curve may come back. We've also heard that if we get this done a little bit too straight and too young of a patient, we can get overcorrection, and that can be a problem as well. We also have some data to suggest that with time, this surgery seems to be less good over time. So the cumulative success drops the longer we watch. Now, again, I think we're all acknowledging that we're getting smarter with this, and we hope that we can bend that curve back up again as we get more experience. But one of those operations that has been really good for us has been a posterior spinal fusion. And I'm going to talk specifically about the selective thoracic fusion. And that implies that we selectively instrument and fuse one of the two curves. And so in some patients, the curve pattern is such that there's a thoracic top curve and a lumbar bottom curve. And you can see in this example where a fusion was done, not of both curves, but just of the top curve, we got a really nice correction of the bottom curve as well. And so we call that the selective thoracic fusion concept. It's a powerful technique, and it's really one of the options for many patients to compare to vertebral body tethering. So not all fusions have to be fusions of the entire spine. However, there are some in which that seems to be our best option, is a long fusion. And the question that we have come up with is, can we combine a posterior spinal fusion with the best of vertebral body tethering? And that combination, in most cases, is a posterior thoracic fusion, just as I showed you, because we know it can get immediate correction and it's very reliable, just as you heard. And combine that with a lumbar tether where we can preserve lumbar motion where that motion counts the most. It's really the lumbar spine that we're trying to save as much flexibility and motion as possible. That's where most of the motion occurs. So in this curve pattern where we have a large thoracic and a large lumbar curve, can we avoid fusing from the top, very top to the very bottom? Will that selective thoracic fusion approach work here? Most of us, I think, feel that 59 degrees is just too big to count on a selective thoracic fusion to do the job. So even though the curve is flexible, that helps. But in this scenario, we're combining that very powerful thoracic fusion with the lumbar tether to help guide the growth of the lumbar and maintain and achieve and continue to gain correction using the tethering principle in that lumbar spine. Here's another example, nice curve. Again, where we fuse these and the levels and etc. are all things that your surgeon will debate with other surgeons, and we won't all agree on this call or this webinar which levels is the right levels to instrument. But we can get good correction, but on a big curve like that, standing up after this fusion won't be successful. And so adding that lumbar tether to put additional correction forces on that lumbar spine so that we can end up with at least maintaining the lumbar mobility, even if we can't maintain all the mobility. So some of these patients might have been candidates for a double tether, as Dr. Larson showed, but this is a way where we can get the reliability of the fusion for the thoracic curve, and the benefit of the tether in the lumbar curve, which I think in some patients might be sort of the sweet spot if you want to think of it that way, as getting some reliability, but also maintain that lumbar flexibility. There are risks of this hybrid approach. The lumbar spine cord, the cord in the lumbar region tends to break earlier, and so failure of that cord can be problematic. Some have advocated using 2 cords. There's some pros and cons to that approach, but again, something to be discussed. And I have another concern, and that is that every patient who would have been a good candidate for selective thoracic fusion may also get a lumbar tether when the selective thoracic fusion would have worked alone. So that's, I think, a risk of this new procedure, and all new procedures have some risk of being overutilized. I think that's one of the risks here as well. And then, like vertebral body tethering in the thoracic spine or in the lumbar spine in isolation, use in patients with insufficient or no growth remaining will not lead to a long-term success, and that growth modulation unlikely to occur if you don't have enough growth to actually change the shape of those vertebrae for long-term success. So again, in a case like this, hybrid's not needed. We got 2 curves, but a selective thoracic fusion works beautifully. You could consider 2 tethers or a selective thoracic fusion. But in a case where that lumbar curve is a little bit bigger, did we spare a lumbar fusion? Or did we overuse a tether? I think that's going to take some more research for us to determine. But again, this is, I think, a nice combination of the 2 technologies that has a potential sweet spot for those patients with a double major curve. We classify these by the Lenke classification, but it's that curve pattern I just showed you. Combining that very powerful 3-dimensional correction of the posterior spinal fusion, and then finishing the lumbar correction with a vertebral body tether and a growth modulation strategy for those that are still young enough. I think this has got some potential for us in the future, and so again, it may complicate the indications a little bit, but I think it's actually expanding some of the patients and improving the reliability. It's a newer technique. We're starting to get some 5-year data on, and I remain optimistic that this will be a nice way for us to improve our outcomes. Thanks. Hope that helps.
Great. Great job, Peter, like always. Just a quick question for you, for our audience. You know, some of the patients that you showed, you were actually fusing into the top of the lumbar spine. Can you just educate us on what your work has shown as you go lower down into the lumbar spine with respect to motion loss, i.e., when does it really become significant as you move down the lumbar spine?
Yeah, I think it's most significant when you start to get really L3 and L4 are where we really lose a lot of mobility. And it turns out it's very uncommon for us to stop a fusion at L2 just based on curve patterns. So we're commonly thinking about a selective thoracic fusion either to T12 or L1. And those, as I have done more of this, I would say that I'm fusing those selective thoracic fusions a little longer, because grabbing the very top of that lumbar curve and twisting it back underneath has been what's made for very powerful correction of the lumbar spine. Even though we're grabbing one of those lumbar vertebrae, we're still preserving the vast majority of the lumbar flexibility, which occurs in the lower half of the lumbar spine. Certainly, if we've got 2/3 of that lumbar motion, we've 2/3 of the lumbar motion segments is probably preserving 80 to 90% of the lumbar motion, because so much of it happens down low. So I think it's worth, again, probably hoping to improve the reliability by grabbing a little bit more of that spine, requiring the tether to do a little bit less work. And so that's been my strategy. I know that we all have slightly different approaches to how we do that hybrid approach, but both my selective thoracic fusions and my hybrid fusions have been getting longer as I get older.
No, we feel the same way. Grabbing the top of the lumbar spine functionally will have very little limitations for motion.
Yeah.